Hello everyone, I'm Dr. Ali Buzurgi, cardiac electrophysiologist, and very welcome back to our ECG Refresher part 10. Today, I'll be presenting an 82-year-old lady who arrived at the emergency department with a chief complaint of palpitations. She has a history of dual-chamber pacemaker implanted 6 months ago due to complete AV block. Let's take a closer look at her ECG. I encourage you to pause the video, carefully examine the ECG, and in a few moments, I'll provide you with an in-depth breakdown of what we are seeing. In this ECG, we observe a heart rate of 120 per minute. The axis of the limb leads and QRS morphologies in precordials suggest ventricular pacing. Additionally, there is a spike before the QRS in certain leads like AVR. Here, this case presents with a paced ventricular rate of 120, pacing at maximum track rate. When pacing at maximum track rate, two possible differential diagnoses arise. First, the pacemaker might be tracking an intrinsic atrial rhythm, such as sinus tachycardia or atrial tachycardia, with the pacemaker tracking each P wave at maximum track rate. The second possibility is pacemaker-mediated tachycardia. Upon careful examination of the ECG, retrograde P waves are visible in inferior leads, these ones, favoring the diagnosis of PMT. What is a PMT? Look at this tracing. In every normal pace beat after the QRS, you will have PVARP, post-ventricular atrial refractory period, which prevents sensing of a possible retrograde P wave in the atrial channel. If this period is programmed too short, or if a PVC produces a retrograde P wave with a long RP, enough to be out of PVARP, it will be sensed by the atrium. Here we can see a PVC resulted in retrograde P wave, out of PVARP, sensed by the atrium, and after the programmed AV interval, it will pace the ventricle. And if this cycle repeats, it would result in PMT. In our case, pacemaker analysis showed upper tracking rate of 120, 99% of ASense V pace events, normal atrial capture test, and acceptable atrial sensitivity safety margin. PVARP was set to 229 and sensed AV delay was programmed to 300 milliseconds. This prolonged sensed AV delay and relatively short PVARP seem to create an endless loop, making PMT. Adjusting the sensed AV delay to 220, increasing PVARP to 300 milliseconds, resulted in the patient's sinus rhythm being suddenly retained, and this ECG demonstrates normal pacing in the same patients after adjusting the new parameters. But in the case that programmer is not available, here are two options. One, administer adenosine to block ventricular atrial conduction, or just simply apply magnets to switch the pacemaker to DOO or VOO mode, effectively terminating the PMT by temporarily preventing the pacemaker from sensing. And that's all for today. If you'd like to learn more about this case, please visit cardiocase.com and read case 581, elaborated upon by Dr. Shayan Shahi. Stay tuned for our next videos where we'll discuss more ECG insight. Thank you for joining us, and until next time.